Oh, yeah, that'll help.
We're good?
Sure.
All right, so my name's Andrew, in case you guys don't know who I am. I'll be talking to you about my case study, which was differential diagnosis postoperative Latarjet procedure. All right, so the purpose of the study is to understand the significance of being able to identify red flags and to demonstrate the importance of applying the biopsychosocial model with this case, and then to gain insight from both the patient and physical therapist perspective. All right, so starting with an outline, the case will be outlined over a period of 5 months. I'll start out with the history and then subjective report of the patient, jump into examination evaluation that we did, followed by some red flags that have popped up and how we handle these red flags, and then treatment session followed by discussion and any questions you want to hear. So starting with subjective and the history, patient is a 25-year-old male student physical therapist. His mechanism of injury was a traumatic left shoulder anterior subluxation playing basketball 7 years ago. So this was back in 2010. In 2012, he started experiencing frequent subluxations around 5 times a year, going all the way up until 2015 when he decided to go see an orthopedist. The orthopedist diagnosed him with a fracture of the anterior inferior glenoid and stated that about 1/3 of the glenoid had snapped off, and this was confirmed with CT and X-ray scan performed. So the orthopedist ended up recommending what's called a Latarjet procedure. What you can see in the picture in the top right-hand corner here is they take the coracoid process and then attach it to the anterior inferior portion of the glenoid where it had snapped off. They use 2 screws to attach it, and so they decided to go ahead with the surgery on August 4th, 2016. The surgery was about 2 hours long, and it included a nerve block, and then afterwards there were no complications noted with the surgery. The patient returned home on the same day, approximately 2 hours after the surgery. And then I'm going to hand out some x-rays here. You guys can pass around. So one is an anterior posterior view and the other one is a posterior anterior view. You can see the 2 screws that are attached. So we're going to pick up the initial examination evaluation, which is about 3 weeks post-op. The patient had been having physical therapy back in his home state of North Carolina, and then came up here to Virginia for school and picked up PT here. So this is where we're picking up the initial evaluation. So this was on August 25th. The patient came in reporting about 1 out of 10 pain resting and 5 out of 10 when moving his shoulder. He reports increased apprehension with shoulder movement, specifically with external rotation at 90 degrees of abduction. He notes aggravating factors including lifting his shoulder, sleeping on his left side, and typing on the computer, maintaining that position. And then relieving factors include pain medication and icing. As for the objective measures, we looked at GH mobility, which was hypomobile for both posterior and inferior glides. And then for passive range of motion, flexion and abduction were at 90 degrees, external rotation was 20, and internal was 40. So flexion, abduction, internal rotation were all within, or right at that goal for the protocol period. However, external rotation was supposed to be around 45 degrees. But that was kind of to be expected with the noted apprehension and the chronicity of the injury. And we also did some palpation as well, and that was noted pretty much throughout the whole shoulder. So looking more into the incision site, the stitches have been removed about 2 weeks post-op, so this is about 1 week after the stitches have been removed. And you note the increased edema in the left shoulder throughout. We looked at the incision site, which had viable tissue growth, so there was no redness, warmth. He also reported no numbness or tingling in his left shoulder, arm, or hand. And then manual muscle testing and active range of motion were not assessed at this time due to protocol. So here is the high AP model. Just to review, its health condition is the post-op Latarjet procedure. Impairments include decreased range of motion and strength. Activities that he had difficulty with included reaching overhead, driving, reaching behind his back to put his belt on. And then he liked to participate in activities such as golf and soccer. And it's important to note participation. He is a student physical therapist in school, so we had to keep that in mind when doing this treatment session so it didn't interfere with school. And then important personal factors included young 25-year-old male. He's motivated, wants to get back to doing what he's doing. There's no comorbidities. And then also keeping in mind the apprehension aspect of personal factor as well. So are there any questions so far? All right, so moving on. So the initial exam took place on a Friday. We're picking this up the following Monday. Patient comes in with 7 out of 10 pain resting. He reports fatigue, malaise, and fever reaching up to 101 degrees over the weekend. He also states that he has an increase in pain at night with some numbness and tingling radiating down to his fingertips. He also reported night sweats, difficulty sleeping. So what we did is we assessed the shoulder with no redness, warmth, or drainage present near the incision site. So kind of based on the things that I presented you with, anyone want to volunteer and tell me what they would do in this situation? No takers. Anyone? Be brave. All right.
I would recommend you go to the physician thinking maybe some sort of cold, flu, something like that going on. Since there's no redness, warmth, or drainage.
All right, so keeping in mind what he said, just keep that in mind as we're going forward through the slides and see if that's kind of in line with what we did. So what we did was we monitored the symptoms throughout a week. There was no change. So we advised the patient to contact his surgeon. We recommended some blood work to be done for possible infection. So the blood work indicated normal levels of white blood cell, red blood cell count, and sedimentation rate. At that point, the surgeon just advised the patient to continue to monitor symptoms, and if there's no improvement, to come back in a week for a fluid analysis from the joint. So we monitored again for another week. Patient continues to show possible signs of infection. There's minimal improvement with range of motion, and the left shoulder is starting to become warm to the touch. So we ended up referring him back to the surgeon with an appointment the following week. So the surgeon then performs fluid analysis, and that just involves kind of sticking a needle in the back of the shoulder here into the joint space and extracting fluid. And they'll run the fluid for tests, and it came back positive for Staphylococcus bacteria. They also wanted to do some blood tests as well, which they analyzed and indicated high synovial fluid nucleated cells, which just points out that there is increased inflammation. So that could either be from a possible infection or just from the shoulder surgery previously. And then high C-reactive protein levels, which is a pretty good indicator that there's possible infection. So what happened from here is the patient was given antibiotics from a surgeon and told to follow up within 1 week. Okay. So he followed up with the surgeon the following week. There was no change. So then what happened was they did another fluid analysis to try and confirm the results. And what happened was there wasn't enough fluid pulled out of the joint, so they couldn't run the fluid analysis again. So they did blood work again as well. This time came up high white blood cell count, red blood cell count, sedimentation rate, and C-reactive protein. So using that blood result plus the previous fluid analysis, it was pretty sure that there was infection. So what they did is they recommended debridement and washout, along with a visit to the infectious disease doctor for possible antibiotics and PICC insertion. So they decided on the debridement and washout, and that took place on October 4th. They put a PICC line in the right arm into the bacillic vein. So as you can see, that's right there. And that's the picture of the PICC line there. So going back to the debridement, is about a 30-minute surgery, and then they initiated vancomycin through the PICC line immediately following the surgery. And then what they told the patient to do was to do a 10 milliliter push of vancomycin a day over a 5-minute period, and that was to be done for 3 weeks, and then have a follow-up with the surgeon and infectious disease doctor after the 3 weeks. And this whole time, orders to continue physical therapy were issued. So this points out the importance of being able to identify the red flags, being able to identify and then categorize it properly so that proper action can be taken. So just to review, based on the size of the article for red flags. We have a category 1, which is automatic medical referral. That includes blood in the sputum, pulsatile abdominal mass, and loss of consciousness. Category 2, which is what we were looking at here, it was required subjective questioning, precautionary examination, and treatment procedures. So we questioned the patient when he first came with the symptoms, trying to figure out, okay, what triggered this, what changed, and then we did some further examination of the joint. We looked at the skin integrity as well, and then continued with treatment, and then saw no change and referred back to the surgeon. So the category 2 signs and symptoms include fever, high sedimentation rate, and unexplained weight loss. And then category 3 is further physical testing and differentiation analysis. And that includes signs and symptoms such as abnormal reflexes, radiculopathy, and unexplained referred pain. Are there any questions about the infection, red flags, and the actions that we took?
So you did the washout, right? And then look at the screws and the hardware.
Yeah, they did another CT scan, looked at the screws, and nothing was, the hardware was fine, so they didn't have to take it out. Yeah. Okay. All right, so now we're gonna pick up, this is 3 weeks after the washout, and the patient had gone from school back to his home, so he picks up PT at another location. Came in reporting about 1 out of 10 pain, still continues to note apprehension with left upper extremity movements. And that's just due to the history and chronicity of the injury. So a quick dash was given, score of 50%, so we want that as close to 0 as possible. The joint integrity being hypomobile for both posterior and inferior glides. And then strength testing for left shoulder flexion and abduction were both 2+ out of 5. And then looking at range of motion, both active and passively. Flexion 121, and about half of that for active range of motion. Abduction 75, for passive, active was 50. And then important to note, external rotation is still at 20 degrees, so there was no change at all throughout this time. We also noted that the patient still had the PICC line in, and then we were unable to do an aptly scratch test at this time because the patient was unable to get to that position. All right, so diagnosis, prognosis, and plan of care. So diagnosis was left shoulder pain, stiffness of the left shoulder, and muscle wasting of the left shoulder. These are all ICD-10 codes that were used. Prognosis was good, but not excellent. And this was due to factors including the increased apprehension, longevity of the injury, and the infection playing a role as well. And then age, motivation, and him being understanding the physical therapy field played into a good prognosis as well. Plan of care was 3 times a week for 8 weeks to return to clinical work as a student physical therapist with minimal limitations. So the 8 weeks would bring him up right to the start of this internship. So starting with treatment, so week 1, what we did is we did a UBE, 4 minutes forwards, 4 minutes back for a warm-up. Did some pulleys for active assisted range of motion. So that was a good warm-up, and then we added in AP and inferior glides. These were grades 2 and grades 3. Grade 2 to reduce the pain that he was having, and then grades 3 to focus on improving range of motion. Passive range of motion, we did all directions. It's important to note, though, we struggled with flexion and external rotation specifically due to that apprehension. So we couldn't do any prolonged holds at the end range because of that apprehension. So we kind of adjust that and play it by ear based on how the patient was doing that day. And then we did some active assisted range of motion with the cane supine in all directions and found better results with that because the patient was able to control his apprehension. And then shoulder isometric walkouts for strengthening. Week 2 continued with UBE, PROM, active assisted range of motion joint moves, and the walkouts as well. And then we added in some active assisted range of motion with focus on eccentric lowered. So we used the cane, and we go up in the flexion with the cane for assistance, and then slowly lower back down. So that really focused on the progression of isometrics to eccentric to concentric for less stress on the tissue. And then we added in scapular stabilization, including rows. And then soft tissue work, found a good article stating that if you combine subscapular soft tissue with PNF patterns, you get a good improvement with external rotation. So PNF patterns for D2 flexion extension were performed in the study, and they got about a 16-degree improvement in external rotation. So we did a reassessment after week 2. Quick dash was down to 29.55, and the MDC is 11.2, MCID is 8% for them. So good improvement with the quick dash. Pain was down to 0 out of 10, so no pain at all. Aptly Scratch were able to do internal rotation to L4, however, he couldn't get to the external rotation position. So that was unable to perform this time. Strength, we saw no change with abduction and then slight change with 3- from 2+. And strength, you can expect it can take up to 6 weeks to change. So keeping that in mind going forward. And then range of motion showed great improvement, both active and passively. Active 60 to 95 for flexion, and then 50 to 80. And then we saw a pretty big jump for external rotation passively, 20 to 50. So we kind of broke that mark of the 20 degrees that he was unable to get past for a while. So weeks 3 and 4, continue with PROM. Patient was starting to become, he was adjusting a little bit to the apprehension aspect, so it wasn't as bad. We did joint mobs continue for inferior and AP, grades 3 now only, no need to do 2 since pain was decreased. Continue with the walkouts, but increase the green TheraBand. We also added in a body blade, and we did both an AP, superior, inferior, and then external, internal rotation, all directions with that. And then added in pull downs, and based on this picture here, you're pulling down, so you're strengthening the lats, but also kind of provides like an active assisted motion for increased range of motion going into flexion as well. So that was a great exercise to incorporate both range of motion and strength. So another reassessment. So after week 4, quick dash was down to 20.45. Internal rotation went up 1 level, and then external rotation were finally able to perform, and I was at C5. Minimal change with strength again. Abduction was 3- from 2+, and no change in flexion. And then continued improvement with active range of motion and passive range of motion. So external rotation noted again went from 50 to 70 passively, 30 to 45 actively. So since we weren't seeing a whole lot of change with strength at this point, we started to focus more on that. We did some PNF patterns with D1 and D2 extension. So similar to the pull down with D2 extension or D1 extension is coming down, so you're strengthening, but coming back up, also improving the range of motion. And same goes for D2 extension as well. And then progress scapular stabilization exercises with wall walks, clocks, scapular squeezes from different heights, so it's a little more functional because you're not just going to do scap squeeze from 90 degrees. We added in some modified push-ups from the table, and then at this point we did some dry needling, and what we saw was we were thinking that there was decreased tissue tension with teres major and lats specifically that could have been limiting flexion. So we did dry needling teres major. Upper trap we did dry needling because he's starting to have some a flare up there, is getting some pain, and that was due to compensation with the flexion. So he's kind of hiking his shoulder, activating the upper trap, going into flexion. And then pec major was also decreased tissue length with that, and that could have been limiting abduction. So what we did is we measured, then we did the dry needling, and then remeasured, and we got about a 5-degree improvement with both flexion and abduction. However, we did that for a few sessions and it wasn't maintained. So each time you come back in, the range of motion would go back where we started. So there was no change. So we kind of discontinued that along with the idea that he was paying out of pocket for the dry needling because it wasn't covered through insurance. All right, and then discharge. At this point, we discharged because it was 8 weeks. He's ready to go to his clinical, and so he would be continuing physical therapy at a different location closer to his work. So looking at the quick dash here, it's 13.64. Aptly scratch and strength, both no change. GH joint mobilization was still hypomobile. However, when you compare it to the initial examination, it was better. And then looking at range of motion again, passively flexion didn't change much, but actively improved. But abduction, good improvement there. And then no change with internal and external rotation. All right, so getting into the discussion. So clinical relevance. It's important to be able to identify red flags, as I showed through this case here. So being able to identify and then properly categorize them so you know what action to take so the patient can get the proper care. And then understanding not all patients follow protocol. So with this patient, he received protocol for physical therapy after surgery. Up to week 3, he was following the protocol, but then that all went away with especially external rotation due to that apprehension and just the overall chronicity of the injury. So that takes into account applying the biopsychosocial model, being able to understand your patient as a whole, and being able to adjust your treatment session based on the different factors. And then finally, everything can be modified. So understanding patients have preferences and being able to adjust to those preferences so that the patient, there's more buy-in with that. Specifically with apprehension is if you're constantly increasing this apprehension, it's not going to trust that. So you have to build up and slowly work your way up so that you can decrease the apprehension and then do more. And then limitations of the study include the infection that definitely set the patient back, the increased apprehension and chronicity of the injury, and then location was also a big factor. So being about 3 hours away from the surgeon, you had to send them back almost every single weekend. And that cuts into your PT time and the patient's time overall with everything he has to do, specifically with schoolwork as well. And then research. So I talked about the apprehension quite a bit, but I tried to find articles that were relating to how you can decrease apprehension specifically. I didn't find a ton of research on it. Found some pointing towards doing joint approximation exercises to help decrease it, but there's not a whole lot out there that I could find. And then some hypotheses we had. So active range of motion we thought was limited due to 2 factors, joint hypomobility, and then active flexion being limited due to short teres major and lats. And then discussion, things I would have done differently, I would have focused more on soft tissue work at the beginning, trying to decrease or increase tissue length with that. Would have done more neuromuscular re-education for proper scapular mechanics, and try and do a little bit more joint approximation to see if that would have paid off for the patient, decreasing his apprehension. And then finally, don't settle for mediocrity. I didn't talk about this, but the first 3 weeks that the patient was receiving physical therapy before he came up here, he was at a clinic that saw him 3 times a week for 30 minutes each. So only 30 minutes, and all they did was passive range of motion. Now, you could have done a whole lot more with that. You could have done soft tissue mobilization. You could have done scapular stabilization exercises. And that could have set the patient back. It's hard to say one thing over the other with all these factors, but it certainly didn't help. So keep that in mind going forward, whether you're the patient or whether you're the physical therapist. Try and do everything you can for your patient. Use evidence-based practice to guide your care so that you can provide the best quality of care for your patients. Here's my references. Are there any questions?
What is the typical protocol after one of these surgeries? Just basically
It progresses from passive range of motion after 4 weeks or 3 weeks, then you can go up to like 125 degrees of flexion and abduction. And then at 6 to 8 weeks, then you can start adding in some strengthening. And then from there, it's 16 weeks that you can do return to sport.
So no lifting really until that 6 weeks, really?
Well, no lifting outside of PT, but they don't want you doing a whole lot of strength training so you can allow the tissue to heal and then strengthen it back up appropriately.
So that test treat retest was utilized with dry needling, which I think is great because you don't want to just keep peppering away at that thing that's not doing it. Was it used, do you think, in the other treatments as far as like after joint mobilizations and to really get a sense of, okay, this is the thing we need to be impacting the most?
Yeah, absolutely. So between, we didn't do it specifically after joint Mohs, we did joint Mohs, passive range of motion, and then retested. And we did see, most of the time it was a good improvement. From the start of the session, it improved by 10 degrees. The problem was maintaining that.
Any self-mobs at home or, you know?
The HEP was not given self-Mohs.
Yeah.
However, going forward, the patient did end up doing more physical therapy. There, they gave self-Mohs. So you can almost do kind of like child's pose and then hold down on like for an inferior glide. Anything else?
Just one other comment, not really a question, but the approximation can work great a lot of times with folks that are where you're just struggling to try to get into some strengthening exercises because they just don't want to move it. I think it does a nice job of firing a lot of stabilizers, and that's it. If they are okay to do that early on, there's nothing contraindicated based upon a surgical procedure or something like that. Try to get to that early because it can just really start some great neuromotor rehab almost. And you kind of forget about it or don't think about it because it's an upper extremity, but it's a great way to get it.
Especially with the shoulder, that's very important.